So tibia shaft fractures are the third most common long bone fractures, and almost 30% are associated with fibula fracture. The goal is here to achieve fracture union with acceptable alignment and avoid complications. So we have an option, either we can treat them conservatively with close reduction and cast, or we have various options for operative treatment. So this is a 10-year-old male who had bilateral tibia fracture. The fibula is intact, and these are the x-rays on the right and the left sides. So I request all of you to start your ARS. So how many of you want to do both sides close reduction and cast? How many for both nailing? Whether right side cast, left side nail, or the other way around? I think there's no E, so I think that all of you who don't opine, I believe that they need little more information before you make decisions. So can we have the ARS? Yeah. Great. So I'm happy for two things. Most of you are awake, at least 35. And I think Sandeep has demonstrated nice tibia casting. So majority are opting now for close reduction and cast. So well, now this side, the left side, there was some amount of graze abrasions and the wound condition was not very good. So the surgeon decided to do left side nail and right side cast, and both have done beautifully. So as we have seen, displaced tibia shaft fracture with intact fibula, what does the literature say? Whether it says to do non-operative treatment or operative? Well, a recent JPO has mentioned that both the treatments are as good, but only thing if for surgical, when you're treating them with just close reduction and cast, you require a longer length of immobilization. Similar article here where they have said that there is low failure rate with non-operative treatment, and recommended that close reduction cast is a very safe and effective treatment for majority, only about 5% where you require a primary surgical intervention, and further studies are needed to find out which are the patients who benefit from day one surgical option. So when we close reduction and cast still remains the gold standard, but you must know for this to be successful that you have to achieve an acceptable reduction. So this acceptability criteria need to be watched for, be aware of, and maintained when you're reducing. So when a child is more than 8 years, you have a very minimal margin. You can accept only about 5 degrees of angulation and almost no posterior angulation. Once you have got a good reduction, for that you must know the good technique, which I think Sandeep has already talked in the morning, and we have demonstrated how to do the good reduction. So I will not talk about it more. But once you have reduced, the post-cast protocol is also equally important. You have to keep them non-weight bearing almost for about 6 weeks, especially for length unstable fracture. And some of them may require additional PTB cast for 4 more weeks, depending upon the age and the type of fracture. And very important is to do a weekly check X-ray, at least for the first 3 weeks. So you still have a window where if you lose the reduction, then you can do some other options, like you will do cast wedging. You can take them for remanipulation and casting, or in some of them, you may have to change your plan and convert to a surgical treatment. So whenever you are treating them just conservatively with close reduction and cast, always tell the parents and the patient that there may be a change in the plan later on if the reduction does not get maintained. So if they are counseled well, then changing the option is not very difficult. But each treatment has its own plus and minus. So the most common disadvantages with close reduction is, of course, maintaining the reduction. Unstable reduction, the literature says almost about 28 to 44% risk of redisplacement, especially during the first week when the swelling subsides and the cast again becomes loose. And of course, you have not given a good cast, then you can have cast complications like pressure sores, compartment syndrome if the cast is very tight. And of course, you require prolonged immobilization. So especially in adolescence and this era of youth where they want to go back to their activity, sports activity, they are not very happy with the prolonged immobilization and close reduction technique. So what are the indications for primary operative treatment? So well, you have some indications, like if the reduction you are not able to achieve by doing a close reduction maneuvers, or if the fracture is very unstable, or if there is significant soft tissue injury, open fractures, where you will resort to a primary operative treatment. And there are certain relative indications if the patient has multiple fractures or ipsilateral femoral, like a floating knee, or some types of patients where like they are very spastic and all, where the maintenance in cast again is difficult. Then these are the relative indications where you will primarily subject them to operative treatment. So among the operative treatment and the various options, I think flexible intramedullary nailing has stood the test of time, and there are various papers where they say that this is a very, very easy and effective method for both open and closed unstable fractures of tibia in children. Of course, here also you have to follow the principles. So what are some tips for nailing? Should always have 2 equal size pre-bent nails which can accommodate and fit almost 80% of the canal. Your entry point, you have to be very careful. It should be distal so that you don't damage the proximal tibia physis, and also sufficiently posterior so that you don't damage the tibial tubercle apophysis. You should not make too many attempts of closed reduction because that may increase the chance of compartment syndrome. You do a mini open if you are not getting a closed reduction, and nails have to be cut short to prevent soft tissue irritation because sometimes that can also lead to periosteal and peripheral perichondrial damage. So as we know that nails, elastic stable intramedullary nail have a lot of advantages, load sharing, they help in, do micromotion, help in union, do not disturb much of periosteal or endosteal blood supply. And it's an easy technique through a small incision and minimal scarring, so it's a patient-friendly technique. But there are complications, just like we have for closed technique. Here also, if you're not careful, if you make too many attempts, rate of compartment syndrome is quite high, especially if the child is obese or if it's a very complex comminuted fracture. You always have the risk of infection. And in some certain fracture patterns, you may have to additionally supplement with cast because nails themselves may not be stable enough, and you may require additional splint or cast, especially for the initial few weeks. So what's the option? Rigid intramedullary nails are an option, but not in very young children, only when the child is nearing maturity, like in adolescence and all, when their physes are fused. And again, you have to be careful in the entry point. You should not damage the proximal apophysis because that can lead to recurvatum. Plating, minimally invasive plate osteosynthesis, sometimes, especially if the fracture is too close to the physis, metaphyseal area, it's a good technique, and advantage being allows early joint mobilization. And rare cases when you have unstable fractures, open fractures, external fixators can also work well. Sometimes they can work as a definitive mode of treatment also, but again, you have to be careful about the pin tract infections and other complications. So after looking and after going through all this, what's the expert opinion? What does the literature say about the modern management of pediatric tibial shaft fractures? And in this very nice article by Fergal Monsell group, where they've given an evidence-based update, they have given this nice algorithm. Looks complicated, but here, if you go through the article, it's very simple. They have devised the algorithm based on the age of the patient. So less than 18, how we have for femur, less than 18, 18 to 5 and all. Again, whether the fracture is closed or open or associated with polytrauma. Again, when closed fracture, whether it's an undisplaced or a displaced fracture, they have outlined what should be the ideal treatment for different age group in different tibia fractures. So to conclude, I will conclude with this systematic review and meta-analysis of closed tibial fractures published in 2020, where they've said that majority, almost 75%, can be treated by conservative. Remember, complications rate are higher in surgical treatment group compared to cast treatment. There are certain predictors for failure of conservative treatment. So initially, only if the fracture displacement is quite high, more than 20%, or if you have an associated fibular fracture, you have to be very, very, very vigilant. They may have to be converted to open. And finally, the treatment always needs to be individualized, not just on the X-ray, but based on what is the age, if there is any concomitant injury, what is the fracture pattern, how is the associated soft tissue and neurovascular injury, what's the experience of the surgeon, and finally also I would add what are the patient demands. So you have to discuss with patients, with relatives, and make a rightful choice. Thank you so much.